They could have a simple surgery, it could be like a hernia repair, problem with vasectomy, and only to find 2 days later they're having blood clots that go to the lungs and they're dead. Had you done this genetic testing just one time, once in their life, you would know forever, and then you would know how to properly prepare these patients for surgery. If these patients have fractures and they're put in a cast or a splint, they need to be anticoagulated. If they go on extremely long trips and they're sedentary, like a transcontinental trip, airplane flight to Europe, that would possibly also be reason for proper anticoagulation. If you're going to put them on anticoagulation, it makes sense to do the genetic testing for VCORC1 and CYP2C9, because if you're going to consider putting these patients on Coumadin, this would be important to the management. If you're going to have a patient on aspirin in this cardiovascular spectrum, it makes sense to test them with aspirin works. That way you can get a urine sample that can be sent off as stable, and you'll know if the aspirin is effectively at a dose that works toward antiplatelet treatment. If your patient has hypertension, that needs to be considered and treated aggressively. Remember what I said earlier about the treatment? We've known for a long time that patients that have uncontrolled hypertension, they have higher levels of mortality, higher levels of morbidity issues. The treatment is with certainty an important part of a cardiovascular risk reduction. However, once you get them treated, do the things necessary to reduce inflammation so in time you can remove plaque and remove blood pressure medicine because it no longer is necessary. It's often very exciting when you have a patient with hypertension, you treat them with medication, only to 4 or 5 weeks later you get this phone call that says, Dr. Fillingham, my blood pressure is 70/40 and I feel weak and dizzy. While that may sound bad to the patient, that just means that the inflammatory insult is under very good control in a short period of time, and you can withdraw the blood pressure medication. Their blood pressure will go back up. You hydrate them, and lo and behold, quite commonly that is the end of the antihypertensive treatment need. However, if your patient is having a problem with hypertension for more than an inflammatory issue, a lot of plaque, a lot of clogged arteries here and there, you treat them with the necessary medication. I personally believe in using an ACE or an ARB frontline if indeed it's possible. You don't have a contraindicating factor that blocks angiotensin in patients that also have blood pressure issues, angiotensin being one of the problematic hormones that circulate and create inflammation. We've got to consider adding the next step, things such as a beta blocker, calcium channel blocker. You're looking at adding hydrochlorothiazide, especially when renin becomes an issue in the treatment regimen. You're also looking at specific areas of treatment. You want to control that systolic blood pressure, in my opinion, down to 120, 130. If they've got problems with cerebrovascular circulation, there is some consideration of bringing that systolic blood pressure down to about 110, and thus being more aggressive if you want to prevent strokes down the road. Years ago, I was having about 3 stroke patients per year. After discussing this with a very brilliant physician from Washington University, we discussed maybe 3 hours of information. I came to the conclusion that where I was having trouble is I was not lowering blood pressure enough in my cerebrovascular patients, and I also was not emphasizing nitric oxide enough in that particular category. It turns out that cerebrovascular disease and coronary disease are different, and how you manage their hypertension would also be different. Biomarkers of heart stiffening. It's very important that you identify the patient that's headed toward congestive heart failure early so you can prevent it from ever happening. Why would you want to be proactive why wouldn't you want to be proactive with preventing this disease instead just taking care of them once they show up with the disease? It makes no sense. If you've got 3 markers, the highly sensitive troponin marker, the NT-proBNP, and the galactin-3, they each measure different things: ischemia, calcification, fibrosis of the heart, 3 different physiologic mechanisms that get your patients in trouble. When you see the NT-proBNP, the test that's probably been done the longest. We've got problems with calcification of your heart, and it's becoming stiff and doesn't want to stretch and receive blood. When you have a galactin-3 problem, you're developing fibrosis of the heart. It does not want to contract as well. When you have ischemia, you're also developing fibrosis, but this time from lack of oxygen. NT-proBNP, when it's barely elevated, you're going to see problems with pedal edema. When you get a patient, Celebrex or an anti-inflammatory medicine, Norvasc or Cardizem, Actos, and you see pedal edema, swelling of the ankles and feet that develops suddenly after the medication was started, you have just identified a patient that is developing diastolic dysfunction from calcification. And probably if you test that same patient, you'll see their NT-proBNP is elevated. You need to restrict salt in these people. You need to consider spironolactone or an aldosterone receptor blocking agent, because aldosterone levels can get as high as 60-fold higher in these patients with developing calcification, developing congestive heart failure. You want to consider ACE and ARBs in those patients. Galactin-3 has to do with fibrosis. The COACH trial was very clearly showing that when patients got a galactin-3 level above 17.9, there was a 20% chance they could be dead within 1 year. When it got above 25.9, there was a 36.5% chance they would be dead within 1 year. If you notice the area below 17.9, there's still a 12.5% chance of being dead within 1 year. A normal galactin-3 is 10. When you see an elevated galactin-3 of, say, 13.5, 15, that's not normal. Don't wait till they become 17.9 to take this level serious. If they're elevating, there's something causing fibrosis. Chronic inflammation is the issue. Go to those 8 disease states and figure out which disease state it is, or which disease states, it's usually plural, and treat each one from an inflammatory perspective. Exercise this patient greater than 15 minutes a day, 7 days a week. You'll usually see the galactin-3 go right on back down to 10, or maybe a little less. High definition troponin, at the 95% cutoff point, you see a measurement of 4.5. That's the area where ischemia is known to start. When you get a level above 7.8, you're at the 99% level. When you get a level above 10, which we saw in the Minnesota Heart Survey, we saw that we had approximately 2 to 7 years warning before these patients had actual events. Now, this was a retrospective analysis, but I think that's extremely useful information. The patients that passed away, there were 211 patients in the Minnesota Heart Survey that passed away during that study when they went retrospectively and did their blood tests from the frozen specimens. It turns out the one with the least amount of warning had 2 years warning. The one with the most amount had 7 years warning. Therefore, there's a long time to allow you to figure out the problem with blocked artery heart attacks when you're doing advanced testing. If this is silent in most people, and it usually is, and you're not doing advanced testing, how would you know to take any action? The patients that are fortunate enough to get advanced cardiovascular biomarker testing, their doctors are going to be pursuing aggressive treatment to make that better. My suspicion is the patients that are asymptomatic without this testing, nothing happens until they actually get in trouble. How sad it would be a patient going to have trouble when you could order a simple blood test and remedy this problem. An old school first generation troponin level will never pick a patient's troponin level below 40 picograms. And if ischemia starts at 4.5 picograms, there's a vast discrepancy between where you need to be testing and where you can test with the first generation troponin. But the second generation high definition troponin testing will pick up 0.78 picograms per milliliter, and that's certainly well below the 4.5 cutoff that we need to be able to see in these patients. With a high definition troponin test, you can find those patients in your practice that have silent ischemia. I believe if you're a physician with an average of 2,000 to 2,500 patients, you'll have at least 150 to 200 patients that have silent ischemia in your practice. Wouldn't you like to know who those patients are before they actually have this heart attack and proactively treat these things? The TIMI 35 trial was very useful in telling us which patients needed a heart cath and which ones did not. You're familiar with the multiple patients through your career years that have had heart caths based on equivocal studies with nuclear testing, there would be possibly some concern whether this area of ischemia is of significance or not, and to be certain they get a heart cath. Why not take your patients that are having stress testing, do a high definition troponin before the test begins, and at 4 hours after or 3 hours after, do a post-stress test, high definition troponin. These patients can then, if they have less than a 2.1 increase in pre to post testing picograms of high definition troponin, they don't need a heart cath. They can be continued to be treated medically. I use a 3-hour testing, and if you use a 3-hour post testing, it's a 2.4 picogram shift. And thus, now you have a means of seeing which patients' ischemia is bad enough for heart cath and which ones are not. This was a very interesting study that was published in the European Heart Journal several years ago. Here we have the information from the Minnesota Heart Survey that I've discussed several times throughout this presentation. You see there's an 8.5-fold increase risk of cardiovascular death in the group that had the elevation of the high definition troponin greater than 10 picograms per milliliter. That is one of the more impressive odds ratios predicting cardiovascular disease of anything ever been done. When you see this highly sensitive or high definition troponin level elevated above 30 picograms, now the risk for heart failure is substantial. As you notice on this graph, even at 1 year, the substantial amount of patients with heart failure is big and statistically significant all the way through the ranks of the years to follow. When you have combinations of NT-proBNP and galactin elevation, you have higher levels of mortality. When you have combinations of high definition troponin and NT-proBNP, you have higher levels of mortality. So obviously if you're calcifying and fibrosing, that's never a good thing. Here you see a case study of NT-proBNP and high definition troponin levels both being elevated and predicting mortality of a more severe nature when you see them simultaneously. When you see sleep apnea and you see depression, we wrap these things up together because mental health problems sometimes correlate with sleep disorders because you make your chemicals in your brain when you sleep primarily. Stage 3 and 4, like we mentioned earlier. The substrates would be the omega-3 index. You want that level getting above 8 to have adequate amounts of serotonin. When you can look at your various ways of treating this, I think it's important that you use substantial amounts of these fish oil capsules over the counter or the Lavazza in treatment of these patients, but certainly you want to get that index above 8. Some people have trouble swallowing fish oil capsules. They make a mini fish oil capsule that's the only one you'll see on the shelf for 1,290 milligrams. These patients will usually have to take 6 to 10 capsules once daily, or they could be broken up in 2 doses to get their index above 8 in most of my patient cases. Vitamin D, also an important hot topic in cardiovascular disease. It affects inflammatory issues in vessels, but it also affects your ability to make serotonin like the omega-3. When patients come in and they have extremely low levels like this 11 vitamin D seen here, they're going to need a rather large dose of vitamin D to get through. In most cases, I would be using ergocalciferol at least 3 times per week at 50,000 units with each capsule. You could use D3, especially in patients with advancing kidney disease, as that may be more effective in those patients. These patients with low D levels, they tend to have seasonal affective disorder, and they have problems with high levels of circulating adrenaline, which is always a problem with cardiovascular disease. I put the dosing that I use for the various levels of vitamin D, depression, and how much ergocalciferol and maximum D3 I would be using in those patients as a result. Thyroid disorders can certainly impact cardiovascular health, and you should be studying that on a regular basis in your patients' workups for cardiovascular disease. Homocysteine levels. This would be the Rodney Dangerfield of cardiovascular disease. There's so many conflicting studies tied in with lowering homocysteine. Helps cardiovascular outcomes. Lowering homocysteine doesn't help cardiovascular outcomes, and then you have to put this information in perspective. I will tell you this. When a patient has trouble lowering homocysteine levels, they do have problems with methylation. Homocysteine comes from methionine. When methionine drops a methyl group, it becomes homocysteine. When you put a methyl group back on homocysteine, you make methionine again. Lack of methylation tends to be a problem in patients with cancer or autoimmune illnesses as they lose telomeres. As you age, you lose telomeres, and then you have exposed genes with bad information, autoimmune here, cancer here, in the wrong environment. With a patient who doesn't methylate proper, they're more susceptible to activate these bad genes. And thus, I think we're going to see more information tied into that in the future. I certainly look at homocysteine as a potential contributor of an inflammatory aspect. I don't think it's controversial, the fact that when homocysteine is high, inflammation is high. The trick is, do you treat the homocysteine or not? If you believe in treating the homocysteine, you want to consider uses of folic acid or methylfolate, vitamin B6, vitamin B12, even trimethylglycine is a potential help in patients with these elevated homocysteine levels. It would not at all be unusual to see homocysteine elevated in a patient with MTHFR genetic defect, because these patients have trouble making the conversion from folic acid to methylfolate. Remember, folic acid does nothing biological in the body. Methylfolate does everything that we give credit to folic acid for. It is the biologically active compound. Depression, I hope you're going to get better with depression once you treat these substrates and you treat the sleep. Sleep's going to have to be a part of your whole factor here. There's obstructive sleep apnea, there's restless leg syndrome, there's narcolepsy. I would tell you in the last 2.25 years, we've diagnosed 24 cases of narcolepsy at my clinic. I'm beginning to believe that narcolepsy is more common than we once thought it was. I was able to diagnose these cases with the use of advanced biomarkers, and that'll be another subject for another day. But suffice it to say, there may be many more patients that have narcolepsy in your practice than you realize. When you do identify these patients, you will actually do an amazing amount of improvement if you will learn to use Xyrem coordinated with a product like Vigil or Provigil to help their alertness in the daytime.